Testing. Good morning, everyone, and welcome to day 2 of our clinical practices track. And today we will have Dr. Ann Bullock starting our session with adversity and the roots of chronic disease. So I will turn it over to you, Dr. Bullock. Thank you.
Okay, hopefully that's on. Not that the room needs it, but for the live streamers. So thanks, guys, for coming to a cheerfully entitled talk called Adversity and the Roots of Chronic Disease, right? Yeah, how much fun can this possibly be? Well, hopefully it'll be some information that maybe you've heard before or in different contexts, but that might be said in a way that kind of puts some things together, I hope, because this is the roots of what we're seeing all the time. You guys are all from different tribal health programs across the USET area, Nashville area, right? Come on in, guys. Appreciate you coming. We're just getting going. We know that last session ran a bit over, so we're glad to have you all here. So my name is Ann, and I'm a family physician. I worked for Indian Health Service for almost 31 years, retired last year. Spent my entire career to one degree or other working with and for the Eastern Band of Cherokee Indians in Cherokee, North Carolina. I still live just off the boundary there. But I was lucky enough to be able to do also some, in addition to that, I was the director for the Division of Diabetes for Indian Health Service, where I should have been living in Rockville, Maryland, but I was luckily able to do it from Cherokee. So got to do a lot of national work around diabetes, and I'm also an enrolled member of the Minnesota Chippewa tribe. So it's this whole topic is something those who've known me for a long time know I've been passionate about for many years. Gave my first talk that said, there's something going on in the medical literature about stress back in 1998. So we've actually known about this stuff for, oh my gosh, 20, 25 years now. But the evidence just keeps getting stronger and stronger, that it's the context of our lives that has so much to do with the health outcomes that we end up having. Well, we're going to talk a little bit about that, of course, at least give an overview of it. That's why I have to point that. It's not working. Where's the magic? It was working. I might need you after all back there, since this is not wanting to do it. You'll flip to the next one. There we go. So this article came out in Pediatrics last year and was written by some of the biggest names in this type of research. Jack Shonkoff at Harvard, who leads the Center on the Developing Child at Harvard. They have wonderful information on their website that's all free. If you guys have any interest in how this early life stress stuff gets programmed into our little brains and bodies, they have amazing stuff. But he is the lead author on this article. It said that significant adversity, which we'll define in a few minutes, especially early in life, is the strongest known predisposing factor for the most common and expensive chronic health conditions. These include obesity, heart disease, diabetes, depression, addictions, and cancer. Well, those are all the big ones right there, isn't it? This is not what I learned when I went to medical school. And probably not what most of you learned in your trainings either, right? That's a big, powerful statement. And we're going to spend this hour exploring different components of why these guys would say that and what we can do about it. For some reason that worked. I don't know why. It's in the ether. So larger context of diabetes. So when I went to medical school, back when the apostles were children, as people say, we're taught, and I bet a lot of you learned too, and I'm going to focus on diabetes. I told you I spent my career doing mostly diabetes. But when I say chronic conditions, it also means heart disease and depression and hypertension and all that kind of stuff all together. But I will use diabetes as the main exemplar here. It was thought to be caused by genetics and lifestyle choices, right? Does that sound familiar to people? Right? That's what it's all about. Well, it's not that that's wrong. It's just not big enough. Okay, we got to expand that. It does matter what genes we inherit. It turns out, and how many of you heard of the thrifty gene theory of diabetes, right? Is that also familiar from probably 20 years ago? That people of color and indigenous people, somehow we had, because of feast and famine cycles, there's this thrifty gene that must have developed. Yeah, that was horseradish. Okay, there's no such thing as a thrifty gene, but it turns out there are a bunch of genes, and you might call them thrifty genes if you want to. And if you happen to inherit a bunch of them, it does increase your genetic predisposition to diabetes. Yeah, it does. But not a whole lot, maybe 10 or 15% if you happen to get a bunch of these genes. But here's the funny thing about them. Those genes, they may affect individuals and families quite a bit, but if you want to look at population level risk for diabetes, they don't explain it at all, because those genes are no more likely on a population level to be in our population as in the white population, the Hispanic population, the Black population, you name it. Does that make sense? So genes absolutely do not explain population level differences. That's important, because how often do we think of, oh, that person's, of course, in our population, they're native, right? So that's why they have diabetes, is those bad genes. No, there might be some families, and I knew some families in Cherokee where I was like, I bet you there's a genetic thing going on here too that's pretty strong, because it's so strong in this particular family, but across the population, not the thing. And even those lifestyle choices, I'm going to put those in big air quotes. Yeah, we make choices and they are important. And it is important that we do the best choices that we can. But even those choices have context, right? With social determinants, what's available, and also how the foods that we eat impact how we feel in our bodies, how they help us with stress, for example. So it's a much bigger context than that genes and lifestyle things by themselves. So if you could get nothing else out of what I say, here are what are those adversities that in that opening quotation? These are the three: inadequate nutrition, psychosocial stressors, and toxic exposures. Okay, you want to know what these things are that are the causes of the causes. These are them: inadequate nutrition, psychosocial stressors, and toxins. And the more of these three things you have, the higher your risk is going to be for developing chronic diseases like diabetes. And there's a wonderful article in American Journal of Public Health just a couple of years ago talking about this. I really recommend. Inadequate nutrition. Let's start with that one just really briefly. So yes, it does matter what our food choices are, as I just said. But a lot of times what we're seeing for obesity is we used to think of, well, we used to have undernutrition, now we have, and we say it disparagingly, overnutrition. Right? Yeah, judging someone on, because they're heavy, right? What we have in a lot of our communities is really something that you might call high calorie undernutrition, because what's shelf stable, available, affordable, right, for a lot of people in our population and others is high fat, high carbohydrate processed foods, right? There's not much good stuff in there. Right? There's not a lot of vitamins and minerals and fiber and all the other things our bodies need. Our bodies know that. So you have to eat more of that stuff. And actually, in several ways, there's a number of mechanisms of which that actually creates more hunger. So people actually eat more because the body knows it needs more. Okay, there ain't much good stuff here, so I'm going to have to eat more of the stuff to get a little more good stuff. So high calorie undernutrition, which seems like an oxymoron, but it totally is not in the food environments of today. And then psychosocial stressors. Obviously, this is huge. This is the whole stress and trauma thing. And I wish we had, more time so we could really talk about how all that adrenaline and cortisol stuff works. That's another talk, but it's fascinating how this all comes together. But suffice it to say that psychosocial stressors, including, of course, racism and discrimination, which for a lot of people is on a daily basis, right? Exposure to community violence, neighborhood quality, adverse childhood experiences, which we'll talk about in a few minutes, income and wealth or lack thereof very often, and what access we have or don't have to resources in our communities, in our society. And the effects of these stressors are directly biologically embedded through stress and trauma and a number of other mechanisms. Again, I wish we had time to go into, but not quite so much today. But also through coping strategies. Okay, so like I already said, if you don't have a lot of great food around, you got to eat more of it. Well, that's a coping strategy. Also, I'll mention in a minute, high fat, high calorie foods actually shut down stress hormones or at least reduce them. So if you have a lot of stress in your life, you're going to eat the foods which actually help you feel better, because they literally do help you feel better on a biological basis, as well as because it tastes good, right? And we're used to it and accustomed to it. And it's available and it's affordable and it's all of those things wrapped up together. And then there's toxins. This is a whole fascinating area that's coming out. There are several hundred at least, those are just the ones that have been recognized, of chemicals, man-made chemicals that are ubiquitous in many of our environments. They're in the air and in the water. It's the alphabet soup of stuff you're seeing in the news now. PFAS for fluoral alkyl, whatever all that is. That's in nonstick cookware and water repellent clothing, a lot of other things. Those have been shown now to be associated with diabetes risk. BPA in plastics associated with diabetes risk. There are so many toxins in the air, the water, our food packaging that absolutely contribute to diabetes risk. This toxin thing is a whole new area that you guys need to keep an eye on, because this is coming out hugely in the literature just in the last few years. Now you take these three things and they're all important no matter when they happen in life. But when they happen, when we're developing in the womb and in the first few years of life, when all of these biological systems in us are developing and getting programmed, so to speak, they're even more sensitive. So this toxic exposure stuff, you can be exposed to micrograms of this stuff in utero, and it can have profound effects for the rest of your life, even long after those substances are no longer even detectable in your system, because they were involved. They were involved with the time that those systems were being developed and programmed. And these things affect people at both the individual and across populations. And so I want to say, it's wonderful that we are connecting our patients now. We're doing little social determinant screenings, right? Do you have enough food? Do you have housing? Things like that, and referring people to services. That's all wonderful and it's essential. But if we're really going to make a difference here, we need to change the stuff at the societal level that makes them need those things in the first place. We're filling the holes, but we're not getting at the thing that's digging them in the first place. So we'll talk about that in a little bit. I mean, that's big, right? That's hard to do at our community levels, but that's the context that we're going to have to go to if we're going to really make a difference down the road in things like diabetes and heart disease risk. And stressors affect health whenever they occur, as I said, but they're especially impactful early. And there's ways that this risk is transferred across generations. Epigenetic ways, literally how many cells are developed in our key organs while we're still in the womb. There's so many mechanisms by which this occurs. Again, something that we don't have time to get into a lot today, but there's so much science behind all of those statements. So let me give you an example of a study that's starting to get at this. So this was a large study, 18,000 adults, right? You don't see a lot of studies that are that large. And what they found was that there was a dose-response association between the number of risk factors, which I'll show you in a second, and onset of diabetes over the following 3.5 years. So they got all these folks, they got lots of information about them at the outset. They didn't want to just kind of say, okay, some of you got diabetes, what happened to you last year? It wasn't retrospective, it was prospective. So we got all these folks, we're going to get a lot of information about them. And then they watched over the next 3.5 years to see who got diabetes. And of those, what information they got at the beginning was predictive. Now, if this was out of the normal model, right, our usual model for diabetes, you'd say it was, well, they don't exercise and they eat junk food and they, whatever, right? It wasn't that list. Having less than a high school education, having financial problems, so the stress of financial issues, being single or separated, so alone and maybe not feeling supported, not having a second income, all that means with that. Just generally speaking, high stress, intimate partner violence, neighborhood poverty, depressive symptoms, and smoking. The only one up there that you might even kind of think was out of our usual old medical model might be smoking. And even that, of course, has why do people smoke, right? That's a stress coping response too. Isn't that interesting? Those were the things that predicted who got diabetes, not the stuff that we usually think of. So food insecurity, I'm going to just take a second to talk about this particular issue just for a minute, because it is huge. We talked about high calorie undernutrition. And we know that this is common. Almost half of households below the poverty level are food insecure, and all households with children, 1 in 5, are food insecure. If you're food insecure, it more than doubles the risk of developing diabetes. And if you have diabetes, it's a significant risk factor for poor blood sugar control, especially at the end of the month. They've done some interesting studies looking at diabetes out of control. When are people go to ERs and get admitted for diabetes out of control? It's the end of the month when the benefits run out. And sometimes now that means you still take your medicines, but your sugars now are dropping because you don't have enough food. Or sometimes you don't have much money for food, but you can't afford that shelf-stable high carb stuff. So your sugars go way up. So it can go either way, depending on how that works for you. Oh, actually, so this diet quality thing, this is a fascinating study. So what they were looking at is, okay, if you take a 2,000 a calorie a day diet, and you have one person who gets their 2,000 calories from fruits and vegetables and whole grains and nuts and seeds and some really high quality protein source, versus someone who gets the same number of calories, but they get it from all that high simple carbohydrate, high fat, shelf stable, chips and drinks and white bread and all the rest of it, because that's what they can afford. That's what's available. Well, it turns out that you will gain weight on this one more than you will on the other one. Same number of calories. Remember a few years ago, American Dietetics Association was into this, a calorie is a calorie thing. Do you remember that? Those of you who've been around a few years. Turns out that's not true. Calories, it matters where those calories come from, because they create different insulin responses in us. That's a lot of what it comes down to, is the insulin response. We used to think people ate a lot of bad junk food, their insulin levels had to respond, stored all that, they got fat, and they kept eating, and that was the cycle. Turns out that it starts out with the quality of the food itself that requires an insulin response. And it's that high, and then the insulin responds, the sugars come down, now we're hungry again. It's the quality of the food that starts this cycle, not just those lifestyle choices. Does that make sense? So diet quality is highly associated with what will happen with weight gain. And as I said, eating these foods make us feel better. They actually affect serotonin levels. That's the same neurotransmitter Prozac works on. So when people say that, it really makes them feel better, kind of a joke I've used is it's no wonder some people's best friends are named Ben and Jerry, right? Because high fat, high calorie foods actually reduce our stress responses. So when you have a lot of stress going on, plus it's the only stuff you can afford and have available, perfect storm, right? Perfect storm. It also turns out that our taste preferences start out in the womb. So if mom is eating just that stuff, because that's all she has available, taste is really just about chemicals, right, from food. So that gets into the amniotic fluid, which the fetus is swallowing continuously. It's a great evolutionary mechanism for the baby to come out ready to eat the foods that mom's eating, right? So we actually already develop a taste preference for the same stuff mom was eating. And if it wasn't great stuff, there you go, we're off and running. And it also increases this thing called allostatic load if you're food insecure. Allostatic load is this, the body can compensate for the hard things in our lives. If we have a lot of stress, don't always have good nutrition, the body can compensate for that to some degree or other, but it comes at a price over time, because those stress responses were only designed to be turned on for relatively short periods of time, running away from lions and tigers and bears, right? And otherwise, not so much. But in our society today, especially if, for people of color and poverty, they're always turned on, they're always running away from lions, right? Those stress responses are always on. And there's a price that is paid by the body to do that. And that allostatic load, as it's called, over time, creates risk for heart disease and diabetes and all the rest of it. Hello. They want to see me. What does that mean? Here-ish.
Because those are our cameras
Oh,
right there,
hi,
and they might be able to see you better from this angle.
got it.
So,
Well, after they see it, they may change their mind, but hi, guys.
Behind you is just a silhouette.
Got it. Never been a silhouette before. All right. Is that better?
thank you so much.
Now I can see where I'm supposed to be, right here. All right. Sorry, home folks. All right. Is this all making some sense, though? Okay. So Congress, about 50 years ago, had commissioned a commission to look at federal response to diabetes, and that commission put out a whole lot of important recommendations about it. And out of it came a lot of research on diabetes, including the national DPP and all kinds of other things, type 1 diabetes research, blah, blah, blah. Well, they didn't do it again until just a few years ago when they created what they call the National Clinical Care Commission, which is a badly named, but it was in the legislation, we couldn't change it, commission that was charged with providing recommendations to Congress on how the federal government could better address diabetes. I was lucky enough to be on that commission, and the report just came out, just went to Congress in January. And it won't surprise you with people like me who are on it, that we, in addition to, we need more health insurance so people with diabetes can get better care and things like that. There was a whole lot in there about the social context being critical for us understanding what we're seeing with diabetes. And in our report to Congress, we said, yeah, type 2 diabetes can be prevented sometimes, and medical care definitely helps prevent complications. Those are all good things. However, the social and environmental conditions that shape people's daily experiences have a huge impact on whether people will develop diabetes or suffer the consequences. I mean, this is big, and we're trying to get that message out in some larger ways. And we've published a few articles in the journals already, and there'll be a series of articles coming out in diabetes care later this year about the commission and this perspective. That if we're really going to address type 2 diabetes in this country, we have got to deal with the social and environmental conditions that are really underlying it. So it's not just adult stuff though, right? As I said at the outset, adversity, especially early in life, is the biggest problem. So the American Academy of Pediatrics, this is 10 years ago, came out with a statement saying that many adult diseases, the ones we've been talking about, should be viewed as developmental disorders that begin early in life. I mean, that's just amazing. Again, that we're talking about that. And persistent health disparity associated with poverty, discrimination, or maltreatment could be reduced by the alleviation of toxic stress in childhood. Well, toxic stress is when children experience severe adversity, abuse, neglect, all kinds of things like that, especially without good adult support of some sort of support that, could be a parent, could be a grandparent, an auntie, teacher, coach, somebody that cares about them and they know is there for them. So that's what they're talking about here. But a key one, and I'm assuming that everyone in this room is familiar with adverse childhood experiences by now, right? This is one category of this. It's not the only one, but it does cover a lot of it. So the original ACE study looked at these, and this is back in the 1990s now. This stuff's been around for 20, 25 years. It's incredible. We're still trying to figure out what to do about this, right? But these were the original categories the original ACE study looked at, and there were 10 of them: physical, emotional, or sexual abuse growing up with a substance abusing, mentally ill, or incarcerated family member, parental separation or divorce, ever seeing your mother beaten, and then 2 categories of neglect: physical and or emotional neglect. And your ACE score was based on how many of the categories, not numbers of times stuff happened to you, but the number of those categories that had happened to you before the age of 18. And today, and even the original ACE researchers have said, well, we didn't know we were going to find that it was going to be so profound. And if we had known more about this at the time, we would have added some more categories: loss of a parent, neighborhood violence. I mean, there's so many other, poverty itself, so many other things would have been included, but just the fact they studied these 10 and got what they got is just amazing. And many studies since then have replicated almost identical findings. And this slide is one that CDC put together a few years ago to kind of summarize it. So the ACE score, that number of categories thing, so this is number of ACEs is going up, bump, bump, bump with the number of categories. So this is groups of people, not individual, not an individual person with each of those, but so groups of people who've had 1 ACE, 2 ACE, and so on. And what they found is that for basically any outcome they wanted to look at, the risk for that went up by how many categories of that experience people had before the age of 18. So whether people had health behaviors, we'll start with the second one, whether they smoked, whether they drank alcohol, whether they used drugs, stair stepped up with the how many ACEs that group had. Whether it was health outcomes, obesity, diabetes, depression, suicide attempts, heart disease, cancer, I mean, you name it, the risk for that, up, 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 based on the number of categories of ACEs. And then whether you were able to go to school and stay in school, get a job, have stable relationships, all of it depended on what happened early in life. It's pretty profound stuff about what happens early. And CDC even did one of their big vital signs things that they do every month back in 2019 on ACEs, and said the very same things as in this slide, and how common these are, how impactful these are. So what happens early, having lifelong effect, and just a few studies that have replicated that. This was just published this year, that ACEs are associated with cortisol levels and patterns. Cortisol is the stress hormone that affects blood sugar, so therefore affects diabetes, of course. It's a mediating pathway for chronic disease. This was a study done in England, looking at civil servants in England, which is very stratified by class. It's a lot of hierarchical stuff in there. Every additional ACE increased the likelihood of developing diabetes across that population by 11%. So add an ACE on, more risk, more risk, more risk for diabetes. And this looked at 10 countries, mixed in terms of socioeconomic stuff. Adults in those countries who experienced at least 3 childhood adversities, almost 2/3 more likely to get diabetes and more than twice as likely to get heart disease. And in fact, the risk is similar to the association between cholesterol and heart disease. You know, we're all about getting people on the right statins, which we should be. That's all good. But just as impactful is what has happened to them across their life. This is all powerful stuff, that what happens early gets programmed in biologically and behaviorally for the rest of our lives. This is a wonderful National Academy of Sciences study, one of their reports actually that came out just a couple of years ago, which I really highly recommend if you're interested in this early life, issue stuff, saying that early experiences and life circumstances shape prenatal stress mom has affects the baby even before they're born. Shape prenatal early childhood development with powerful impacts on the developing brain and body that shape health outcomes across the life course and can span generations, this intergenerational transmission of this. So over and over, seeing very, very highly prominent researchers and reports all saying the same thing, that life context is what's happening, what we're seeing in terms of creating this risk for these chronic diseases. It's not only about individual lifestyle choices and genes, it's about the larger social context that they have, especially when they're very young. Even back prenatally, I wish we had more time to talk about prenatal stuff because there's so much science on that now, but we know that high levels of both racial inequality and socioeconomic inequality increase the risk of being born small for gestational age. Okay, so, gestational age, so if you're born at 40 weeks, but you're small, you can be full term, but small for that, or you can be preterm and small for that average, but just being born small. So the high levels of both those kinds of inequality, especially when they happen together, increase the risk for being born small for your gestational age. We also know that maternal stressful life events in the first trimester, before a lot of people even know they're pregnant, increases the risk of preterm birth almost 2.5 times, which is huge. And you might say, well, once they get out of the NICU, who cares, right? Well, being born early and or small, and especially both, are strongly associated with your later risk for heart disease and diabetes. So again, what happens very early, having lifelong impact on how it gets biologically embedded in the body and how it stays that way for the rest of our lives. And in fact, saying that psychological distress at any point in the life course is associated with higher heart disease and diabetes risk. Even if things seem to get better as we get older, hopefully we get a little less stress in life. Maybe we had a really tough childhood, but things get better. We're able to sort of straighten things out. But the heightened risk of cardiometabolic disease remains. Early emotional development may actually be a target for primordial, as they say, primordial before primary prevention, right? And promoting lifelong cardiovascular health. Often see the cardiologists talking about the fact we need to help pregnant women and young children to have better lives in order to prevent heart disease. But that's exactly what we're saying here. So intervention examples. So what do we do about all this? And there is starting to be the science around, so you want to connect, the problem to what's causing the problem. And then you want to find out what you can do about the problem, right? And just because you know that something goes wrong doesn't mean that something that fixes this necessarily fix the original thing, right? So you really do want to study these things to make sure that you're putting your scarce resources towards stuff that's really going to work, that's really going to help. So prenatal and early life home visiting, can't resist that one. You all know what that is. I mean, home visiting sounds like you go over for tea or something, or I don't know, but it's a very usually intensive, the more intensive usually the better, where specially trained either nurses or community workers work with pregnant women, and then once they have their kids, their young children, sometimes there's not a prenatal component, sometimes it starts at birth, but they go in and do coaching and help these young moms and dads, if they're involved, to be better parents, to connect them to resources, to improve their food availability. There's lots of evidence about the nurse-family partnership is the oldest and best studied one, with very good data going out several decades after the intervention, showing that kids whose moms got that intervention do better. Family Spirit is a home visiting intervention specifically created with our population in mind. This one is one that Yale University developed called Minding the Baby, and they studied outcomes on that and found that it significantly lowered the rate of obesity in poor, low-income 2-year-olds, and also even in Hispanic kids, reduced the risk for obesity. So, even seeing results early, even the first couple of years of life, helping with the right things to happen at those key developmental stages can make a difference over the long, for the long haul. So home visiting, one tool in the toolbox. This one is looking at daycare. In our society, moms often have to go back to work, often, 6 weeks. Maybe you get a few months, maybe, but a lot of places no. So where are kids spending most of their waking hours? It's in daycare and childcare. And yet it's often the place that we spend the fewest resources, in our communities. This looked at providing quality childcare, actually in low-income area in the Raleigh-Durham, North Carolina area, for cohorts of disadvantaged kids born in the mid-70s, and the intervention was provided from birth to age 5, so they didn't have a prenatal component here. And the intervention was teachers who worked one-on-one with the kids to develop language skills, emotional self-regulation, can you, share? Can you control your emotions when things don't always go your way? Those are things the brain's learning in those early times. And it's so important for those brain pathways to learn that and wire them together early in life, because it'll help them for the rest of their lives. So this development of language, emotional regulation, and cognitive skills, just so critical. They also help with parental skills by bringing the parents in and supervising them as they play with their kids and providing coaching on, okay, you don't have to scream at Johnny for this. Or, Johnny's really out of control here. You might want to kind of try to corral him in a little bit here or whatever. But it was coaching to help these parents be better parents to the kids. They took care of the food insecurity issue with nutrition and provided primary pediatric care. So now they studied these kids 30 years later and found that the kids who got this when they got this when they were kids. Now adults, they had lower prevalence of heart disease and diabetes risk factors, including better blood pressure, A1C, obesity, and better cholesterol, 30 years after providing this intervention. There's really nothing, in some ways, we think of all the services in our communities that are essential, and there are so many, but there is not one more essential than the daycare we provide. You don't usually hear that in a diabetes talk, do you? But you think about how impactful the food that kids eat there, the relationship building. Do they have one teacher who can look them in the eye and talk with them and really communicate with them, let them know that they are important, teach them essential skills? Or is it one teacher for 32-year-olds who, running all around, who can barely keep them from, mutual suicide, running off cliffs or something, right? As opposed to really giving them the skills that they need. But we don't give daycares enough resources, right, to have really good teacher-student ratios, right? What are they in your community? Hopefully they're really good. Hopefully your tribes are putting a lot of money into this. If they're not, this is something that really needs to happen, because really what could be more impactful? Because that's from almost birth up until these kids go to kindergarten, right? By the time we go to kindergarten, a lot of those brain wiring things, the windows of opportunity are already starting to close. This is the critical time. Improving income. Some of our tribes in this area have gaming. Many don't, but some do. Improving income can help. A lot of tribes have other ways of trying to help their folks with income issues. This is not done in our communities, but a lot of these studies are actually based on some from our communities, showing that per cap and other things that improve income actually are improving outcomes way beyond just, can people afford to buy better houses or cars? This is a study done out in California called the Baby's First Year Study, and you're going to be hearing more about it. This made the news just a couple months ago. Where they were been giving what they called high income, which was $333 a month. Like, that's a lot of money. It's not, but that compared with the control group who got just $20 a month. These income supplements given to moms experiencing poverty at the time, so they started the birth of the kid, result in already showing better brainwave patterns, healthier brainwave patterns at age 1. Just because mom wasn't as stressed, was able to buy a little better food, maybe, not feeling as stressed, maybe a little better parenting. There's probably a whole lot of mechanisms at work here for why just that small investment is already showing better developmental stuff for the kids. This is important stuff, and they're starting to follow these kids. I mean, they're only a year or so into the study. We'll be seeing a lot more coming out on that. So keep listening for more on that study as it comes out. This study was done in a Native community, and the longer kids were exposed to income supplements per cap from gaming, the lower the rate of psychiatric and substance use disorders as adults. So less stress, better food, better parenting. In fact, we know from some of the other studies related to the same one here that better parenting actually did happen. Parents felt less stressed because they had more income, they had better jobs available because what gaming brought to the community, and it improved their ability to parent, and it had impact on their kids years later. What happens right? So just as what happens wrong early has lifelong impact, what happens right early has lifelong impact. And this was in California, tribes that opened or expanded a casino during the time of the study. This is a measure you probably don't see very often, which is slot machine per capita. How do you like that for a measure? But for more slot machines in their casino per population of their tribe, which is allowed for more income, right? $541 in per capita annual income, which still isn't a lot of money, right? $541 a year increase, that's not huge, right? But even with that, it decreased the probability of their kids being overweight or obese. Is it better food, better parenting? It's all of it. It's not either or. It's this whole constellation of ways that this stuff, either for good or for ill, gets embedded in us. We know that SNAP is awfully important as the biggest food program in this country. So the Supplemental Nutrition Assistance Program, or food stamps, as we still sometimes call it, studies have shown all kinds of things for that. Participants have better nutrition, of course, because they're getting food, right? And reduce food insecurity, which you'd expect, right? If you give people food, they should be less food insecure. But in addition to that, they have better health. They have lower healthcare expenses. Again, they're less likely to have that end of the month in the hospital for diabetes out of control and all the rest of it. Children with access to SNAP do better. They do better in school, and they follow these kids out to adulthood and they do better. So when you reduce food insecurity, not only do you improve nutrition, you decrease the stress, that allostatic load, all of that together, showing better stuff, not only at the time, but years down the road. It's one of the best investments the federal government makes is SNAP. And anything we can do to increase SNAP access and eligibility, and especially trying to make the foods that are on the SNAP, the foods that you can get on SNAP, try to target those a little more so that you can't get sugar sweetened beverages and other things like that, which is a big area of controversy. So much the better, sort of like WIC does by having a food package. But SNAP is an incredibly important thing. This was called the Moving to Opportunity Study, which really turned a lot of people in the diabetes community on their ear, because they were like, what is that about? So in this study, housing vouchers, this wasn't about providing more low-income housing per se, all the high-rise low-income buildings where unfortunately all kinds of problems just end up becoming more concentrated. They provided housing vouchers to low-income women to move to higher income areas. So they moved them to higher income areas, and they had lower obesity and diabetes from living in a place with less neighborhood poverty and less community violence and less all of those other things. Just moving to a better area improved their health. Again, not what you'd expect if you're just thinking about the usual ways of looking at chronic disease. So poor nutrition, psychosocial stressors, and toxins are the causes of the causes, right, for chronic disease. So if you've heard nothing else, I hope you're hearing that one. They're the causes of the causes. They cause, the choices, people make, they frame them. They affect our biology. I know we've had to kind of gloss over some of those mechanisms for lack of time, but they are the causes of the causes. So macro level policies that affect these for good or ill in populations, especially in populations like ours with lots of these challenges, we need to make meaningful improvements in those social environmental factors, in those three things, and take the larger and longer view on cost and benefits. So some of you are providers, I assume, of one type or other in your communities, and you're going, what do I do about this? I can't change, all the societal level stuff. I can't, change SNAP policy. I can't, all these other kinds of things, or at least I don't have much impact on it. So what do we do with this? So I want to make a few suggestions. One is, when we can, we should advocate for them. Anything that helps improve any or all of those three things, nutrition, stressors, and toxic exposures in our environment, anything that reduces that is going to be good, right? And we've seen some interventions that are doing that and are showing good. So advocate for those things. Get involved where you can with organizations, or just write your congressional delegation on things that you think are important. We don't want to ever forget that as citizens, we have that right to have an impact at that level. But then we also need to do stuff where we have a little more impact, perhaps, and that's locally. So, and you're at the tribal level. A lot of our tribes kind of own, if you will, or manage most or all of the health and social services in their communities, right? Maybe not all of them, but have taken on a bunch of them. So there are things that tribes can and are doing and could do more of to help bring these issues very consciously into their planning for what they do and for the programs that they develop, the grants they go after, whether they are bringing together programs. There are some Indian communities where there's so many different types of home visiting programs, they practically have to schedule time with their clients, because they're like, no, which organization are you from again? Whereas if you can collaborate and try and bring those services together to be more efficient and more relationship based with folks. But Head Start, childcare, I think I've tried to make that point really clearly. Those are huge. Parenting skills training, home visiting programs, anything that provides financial support, working with the criminal justice system. One tribe provides parenting education to inmates at the tribal jail because they know that when those folks get out of jail, they're going to go back to those homes with the kids in them. And if they haven't learned something before they go back, they're going to be the same kind of parent they were before they went in. I mean, think about these, collaborative kinds of things. Another tribe doing behavioral health referrals right from court, the court able to make those referrals for parenting training and for behavioral health counseling. There are ways to collaborate to create programs right in our own communities that can help reduce those kinds of stress. It's that balance between toxic stressors and good things, things that do it right. And try to lower one and increase the other. Wherever we can do that, it's going to be better. And then look right at your clinic or at your service organization, whatever you work for. What can be improved in the processes? Do you have people who are coming into clinic? A lot of them are very stressed. Do they come in and they're going, okay, I don't even want to be here because this is where, my grandma got told she was going to die from her kidney failure, or this is where you guys told me, that I have diabetes or I have heart disease. I don't really want to be here at all. And then I come in and maybe I'm 10 minutes late because I couldn't get myself out of the car in the parking lot because it was just too hard. And then I come in and you all yell at me because I'm 10 minutes late, and now we're going to have to reschedule. Are there ways we can make a difference to some of our processes? Are there ways that we can, in some of our really well-meaning posters on the wall, we take this opportunity to educate people, right? I remember, I think it was even one of the clinics I worked in, back in the day, you still see these posters sometimes with someone who would use chewing tobacco and their face was half eaten out. And here you have this poster on the wall and it's intended to try and get people's attention that using oral tobacco is a bad thing, which is a good message. But did you really have to show that traumatizing poster on the wall for someone who's already stressed by being there in the first place? Probably not the best way to either get that message across, because tobacco actually helps calm people down, right? They probably went out and had a smoke just looking at that, right? I mean, sometimes we shoot ourselves in the foot on this. So on clinics' physical appearance, I know we don't always have a lot of money for improving our clinics, but maybe we could put in some natural lighting, or not the fluorescence, and a lot of tribes have been working on this great. It's nothing now like it used to be way back in the day, right? But anything we can do to make it to less trigger people into being even more stressed about being there than they already are, anything we can do to help them with that is going to be good. Being a little more comfortable out there, maybe the seat cushions are getting a little worn. Can we just replace anything that helps people to feel a little better is going to help. And most of all, we need to be aware of how we react and interact with our communities and our patients. Like us, providers and clinicians and professionals, we always do it right? Oh, come on, we don't. Let's be honest, we don't. Okay, we bring, as someone said at the last session, we bring our biases in with us, right? We bring our fatigue in with us. We bring all that stuff in with us. So let's go back to ACEs just for a second. So what would you guess? Nobody knows, and we don't need to go find out the answer to this question because we know it's high. And so, but what would you guess is the average ACE score of the people like in your county, both native and non-native? Just throw a number out. We don't know. Just make a guess. 5. Okay, 5. All right. What about in your particular tribal community? What would you guess is the average ACE score? Just guess. We don't know. Another 5. Any other numbers? 8. Okay. How about the patients or clients you work with as a group? What do you think? What would you guess? Not that you needed to go ask them all of this. You don't necessarily have to. It's screening for ACEs is a whole other issue. We aren't going to have time to get into whether it's a good idea, and if so, whenever. But What would you guess? 7? Okay. So we have some highly traumatized folks, right? Right? Do people who've had a lot of trauma in life come in calm, cool, collected, never respond when things, kind of harass them a little? No, it gets wired in, right? So what about us? My A score isn't 0. I'm not asking y'all, don't shout out numbers here. But what's our A score? If we're like the folks in the original A study, 2/3 of us, it's not 0, right? And if we add in those other types of stressors that they didn't measure in the average back in the ACE thing, right? Then the answer is all of us have had trauma. You can't get out of childhood without something happening to you that overwhelmed you that you didn't understand maybe because of how young you were. All of us have had trauma, all of us. So people who've had trauma are seeing people who've had at least as much trauma as us, maybe more, depends, right? Does that a potentially volatile mix, or one in which we might stand to not always understand each other or not respond calmly and clearly and appropriately to each other? Of course. So how, we might ask ourselves how those experiences have affected us in life. Because they do, right? And if we can own them, so to speak, and they can help actually engender compassion and understanding, right? Because, this is where we take off the white coat, if we wear them at all, but, take it off proverbially. And we say, I'm like you. I am also human, and I also have had struggles and challenges and trauma in life, so I can understand what's going on for you. So when we work with our patients, we need to recognize that their behaviors are often coming from all these hard places, right? Maybe they're not eating well, not because, they just want to, tell you something, right? But because they can't afford it, right? Or it's not available, or they don't have gas money to even go to the store, whatever it is. And different situations will cause different people to feel stressed and respond from those traumatic associations. Depends on what you've had happen to you that got wired together in your brain, right? So talking to authority figures, we don't always think of ourselves as authority figures, but to patients and clients, we are. So, if they grew up with a parent that was hard to talk to, right? Or, yelled and screamed or whatever, do you think maybe they might project that onto us? Sure. Any unfamiliar or challenging situation, like talked about going to clinic itself, exercise or hunger can trigger traumatic associations because exercise gets your heart rate up and gets that adrenaline flowing, and that can make it feel just like when things were really hard, when you were a kid. And hunger, if you went through stages of life, even before you can remember it, where you didn't have enough food, it gets wired into your brain that hunger could be dangerous. So sometimes people overeat just because they can't ever, it's too terrifying to feel hunger. So I'm going to eat and stay eating all the time because that is better than that feeling I have inside me that I can't always put my finger on and tell you what it's about, but that's too hard to deal with. And we need to be aware of our own responses, including our tendency to judge our patients. And I'm telling you, as a physician, we're all in a safe space here, right? We judge our patients for everything. We judge whether they're too heavy. We judge whether they're exercising, whether they drink, whether they use drugs, and whether they are messing up our GIPRA indicators. Doggone it. Your A1C is high, and that is going to mess up my GIPRA numbers this month, and that just stinks because I'm going to get yelled at by my clinical director or my nursing supervisor or my whatever, right? So we tend to, our healthcare system, those performance measures that started out way back in the day, they got thought up by somebody who was saying, well, maybe we can just kind of see how well we're doing and maybe just get better. And then they became sticks on which healthcare folks get beaten with, right? Yeah, we all know that. So that makes it extra hard for us who are usually type A types in the first place, or we wouldn't be in healthcare, right? And got all that professional training and stuff that we do, and if we're not seen as good enough from our performance measures, oh my gosh, could be hard. So my last point is that when we look at all of this, we realize that there's so many hard things that have happened to our patients and to us, and that we are human just like they are, that compassion, it's a very healing thing for both us and for them. So look at the big picture. The person you're seeing is the result of so many things that have happened in their lives. And yes, their choices, and yes, that drive, that spirit that we all have to be better, to connect to something higher and larger than ourselves. We are all the product of all of those things together. But sometimes the hard stuff really, plays out in ways that we see in clinic, and they play out in the form of chronic diseases and other things. And so being compassionate with them and with ourselves and saying, we're on this journey together, this thing called life, right? And we can, instead of judging each other, we can realize that there's much larger things going on and just be with each other, on that journey together, doing the best we can. All right. Hopefully that was enough on adversity, and I appreciate you all coming. Thanks very much. And thanks, home people.
Thank you so much, Dr. Bullock, for that great presentation. I know we're running close to 11, but I just wanted to open it up for any questions. If anyone has anything you want to ask, go ahead.
There wasn't in that study. There are, and this gets a little beyond my expertise as staffing for things like that, but there are definitely best practices out there for teacher-student ratios. And obviously, if you have special needs kids, in daycare, which, we have them early on in life with that too, kids that were preemies and, kids that we're dealing with substance abuse withdrawal after birth. I mean, there are so many really such high risk kids early on. Obviously, you need, probably one-on-one if you can with those kids. So, but there are best practices out there for that. I couldn't give you a number otherwise, but definitely that's there. But so important that where we can, we staff to that. And the other thing is that it's not just the teacher-student ratios, which are critical, but the other critical part is the consistency of those teachers. So if you don't pay people well, or you don't make their work life good, I mean, these are often people, these are not always the strongest people in our communities who work in our daycares, right? Because we pay so little, right? We need people, we need to pay enough that we get people who have good emotional strengths within themselves, who can work with children in good ways, and who will stay, because this becomes one of the most critical relationships in that child's life, is that daycare teacher, because that's where they're spending a lot of their waking hours, a lot of times far more than they spend with their own parents. So it's do we pay them enough? Do we take care of those teachers? Will they stay? And do we have enough of them to do the right things with those kids at those critical developmental periods?
Nutrition and getting, food into those families and those kids. Are there any studies out there that you look at that address and or looked at SNAP versus food deserts and transportation? Because it's one thing to actually have police, but it's another thing to actually have a grocery store to go to and
Right.
the transportation.
Right. So SNAP is important regardless, because you can at least get some food. But right, if you're out in the middle of a reservation and all you have is the res store, the convenience store at the gas station, or you're living in an inner city, and again, that's about all the same kind of stuff you have. There's a real pattern there, right? Right, that's a problem. It clearly. There are some initiatives around SNAP, and if you actually read that National Clinical Care Commission report, we talk a lot in there about increasing SNAP, and there have been some demonstrations within SNAP on fruit and vegetable, increasing that as part of it, and trying to get that out to areas more that haven't had access to those things. There's definitely efforts in that regard, but right, being able to get at those larger issues of is there a good grocery store, in your community is huge. There's no way around that. So I don't know about a study that looks at exactly that, because there's so much variation on the theme, but right, SNAP is good, but having access to those better foods is an essential second part to that.
There an average age in our populations that you see where allostatic loading is realized, and it's maybe kind of subjective for a certain chronic, say for cardiology, diabetes, is there an onset age?
Yeah, it's before birth. There's some fascinating work out there on, again, we didn't have time to get into in utero and early life stuff. You'd be here all day. You'd just love it. Just kidding. So if mom has either or both of a lot of stress herself during pregnancy, and or she had a lot of adverse childhood experiences herself, so she's already got ramped up stress hormones to even normal stuff, let alone the extra stressors in pregnancy, and or if she has undernutrition, you end up with the baby is already born with a toxic metabolic profile. They already have fewer, if there's enough undernutrition, there's fewer cells in the kidneys, in the heart, in the pancreas, including insulin producing cells than would have been otherwise, because the body didn't have enough nutritional building blocks to make the good stuff. So they had to make do with what they could. There's alterations in set points with stress hormones in the baby, because some of mom's stress hormones will cross the placenta if they're high enough to overcome an enzyme in the placenta that's designed to buffer that. That changes the baby's own stress hormone set points for things like cortisol, which affects blood sugar. And it also affects visceral obesity. So that's the obesity, the fat that gets laid down within the organs, right? Which is even more metabolically active than the stuff we carry here and even out here. So you see kids already born with these metabolic derangements. So what's the age we're seeing it? It's before birth for some kids. And then of course it just only accelerates and accumulates if things are not better in the early childhood environment. So yeah, really, really, really young.
So we focus on adult nutrition
Mm-hmm.
and what about our kids? We focus on, mothers and, even but after that, there should be equal education on nutrition, or should we focus, try to focus most of our education on children? Where you trying to
Yeah, right. How do you spread yourselves that you're already thin? How do you spread yourselves thinner, right? So some places, and it's a great question, of course, when there's so many problems, where do you focus? One of the things I just mentioned very briefly about nutritional building blocks to build babies' bodies in utero. Half of those nutritional building blocks mom ate while she was pregnant. The other half she ate before she even became pregnant. So one thing you could do is work on the nutritional quality of food in the schools, right? Because who are the ones that are getting pregnant? It's adolescents very often, and older, but because you can't go back. Once they're pregnant, you can't go back and say, oh, we're going to improve your nutrition you ate before you're pregnant, because you're pregnant. You need to improve that during pregnancy too, but you already missed that first opportunity if you didn't have it before. So trying to improve nutrition for schools. Schools are so strapped for funds, and now with the increase in food costs, I know right around our area, we're seeing that they're increasing the cost for low cost breakfast and lunch. Well, increasing the cost at all will price some kids out right there. So anything you can do to improve quality of nutrition in schools would be a great place to go, because you're going to hit that population that hopefully isn't pregnant yet, but some of them will become so. And also, it's not just mom's nutrition. There's evidence on dad's nutrition too, because of epigenetic mechanisms. So we need to focus on not just the girls, but the boys too. So anywhere in there, dive in, there's so much need, but that would be one. The thing about schools, of course, also is that you can often, if you can help provide more resources and help the school staff that provide nutrition services in any way. First of all, they're gonna be grateful because nobody usually pays attention to them, like no one pays attention to daycare workers, right? But these are places in our communities that we are really missing opportunities to do the right stuff, and that population is so concentrated there. Whereas once they graduate, it's harder to make an impact. So that's just one thought. Yeah, and daycares, improve nutrition in the daycares. Absolutely, whatever you can do there. I remember one tribe up in the Northern Plains that's out in the middle of nowhere, and what it took for them just to add fresh grapes to the kids in the daycares. It took a lot of money and effort for them to go get them before they spoiled, because the stuff in the res store was one rotten lemon and some wilted lettuce is all they had, right? So they had to go to the big city to get even that. Whatever you can do just to bring in better nutritional quality, those would be two good places to do it. I know we're past, so.
I don't have any other questions before we go. Okay, well, thank you again, Dr.
Thanks,
Bluff,
y'all,
for
for
that
coming.
great
Appreciate it.
presentation. It was a little bit from USET. Thank you for your time. And everyone have a great rest of their day.